Pacing techniques. Modern pacemakers. Modern pacemakers have several advantages over older generations. Lightweight, 25 to 40 grams. Pacing, fully programmable for dual-chamber pacing. Sensing, algorithms to respond to changes in intrinsic rhythms. Rate response to physical activity or metabolic changes. Telemetry follow-up is possible. Storage of a history of the patient's arrhythmic events. Pacemaker implantation. Pacemaker implant was initially a major surgical procedure requiring thoracotomy in the operating suite. Currently, nearly all pacemakers are implanted through a transvenous approach, by either cardiologists or surgeons. Pacemaker implant, however, is usually performed by cardiologists in the cardiac catheterization laboratory, which usually costs less than the operating room. Venous access. Venous access for lead placement may be via a cephalic vein cut-down. Subclavian vein access is technically easier, and can almost always accommodate 2 leads, but it has some disadvantages. Risk of puncture to the subclavian artery. Risk of puncture to the apex of the lung. Medial placing of the leads may be subject to lead fractures or insulation breaks because the leads may be gradually crushed by the clavicle or the first rib. Pacemaker system. The basic pacemaker system consists of a pulse generator with a battery. 1 or more leads connected to the pulse generator. Electrodes attached to the distal ends of the leads. Permanent pacemaker leads. Permanent pacing leads have 5 major components. 1. Connector pin. 2. Conductors. 3. Insulation mechanism. 4. Fixation mechanism. 5. Electrodes. Here is a diagram of the pacemaker system, the pulse generator and the lead with its connector pin, conductors, insulation and fixation mechanisms, and electrode. The detailed lead components are shown here. The insulator is covering the conductor, and the electrode is present at the inner tip of the lead in contact with the heart tissue. Types of pacemaker leads. Pacemaker leads can be unipolar or bipolar. Unipolar leads use a distal electrode in the catheter as the cathode and the shell of the pacemaker generator as the anode. The myocardium and adjacent tissues complete the electrical circuit. A bipolar lead consists of 2 separate conductors and electrodes within the lead. The unipolar lead has 1 conductor and cathode electrode, with the pacemaker shell acting as the anode, while the bipolar lead consists of 2 separate conductors and electrodes, cathode and anode. Advantages of unipolar lead systems. Simpler to design. Less likely to fracture or develop insulation breaks. Smaller in diameter, consequently, it is easier to pass 2 unipolar leads through a cephalic venous approach. Disadvantages of unipolar lead systems. Most leads implanted nowadays are bipolar, due to the following disadvantages of unipolar systems. Possibility of muscle stimulation because the unipolar lead uses the body tissues to complete the electrical circuit. More likely to pick up extracardiac signals, such as myopotentials and electromagnetic signals, as well as remote cardiac potentials, far-field sensing. Cannot be used with a concomitant implantable cardioverter defibrillator. Pacemaker signals. Bipolar signals are sharper, with less extraneous noise, because the sensing electrodes are much closer together. Leads fixation. Leads are attached to the heart by active or passive fixation. Active fixation involves the use of a screw within the lead system that fixes the lead to the heart. Active fixation leads are used more in the atrium. Passive fixation utilizes short extensions proximal to the distal electrode, which attach to myocardial tissue to hold the lead in place. On lead placement, ensure adequate pacing and sensing thresholds, and keep an adequate safety margin, since acute pacing and sensing thresholds during implant may degenerate over time. Pacing threshold. The pacing threshold is expressed in 2 quantities. The minimum stimulus intensity in millivolts, MV, and the width or duration in millisecond. The pacing threshold can be calculated by holding the pulse width constant, for example at 0.5 millisecond, and automatically decreasing the voltage in 0.5 volt decrements every 4 complexes. In this example, pacing was maintained at 3, and at 2.5 volts, but was inconsistent, with loss of capture, at 2 volts. Therefore, the voltage threshold in this patient is 2.5 volts at 0.5 millisecond width. Choice of pacing thresholds. The choice of the pacing threshold necessary to capture the heart depends on the indication for pacing, because of the inverse relationship between current drain and battery life. For example, in a patient with hypersensitive carotid sinus syndrome, who would only use the pacemaker sporadically, a higher pacing threshold may be acceptable, than in a patient with permanent complete heart block, in whom it is expected that there will be 100% pacing. Goals of pacemaker follow-up. Optimize pacemaker parameters. Monitor pacemaker generator and lead function. Maintain patient records. Optimize pacemaker parameters. Pacemaker parameters should meet the patient's needs during rest and exercise. Minimize pacemaker-related problems and complications. And maximize longevity of the pulse generator. Patient records. Maintain patient address and telephone number. Educate the patient. Anticipate need for pacemaker generator replacement. Transtelephonic monitoring. Transtelephonic monitoring has very limited capabilities and should not replace periodic direct evaluation of pacemaker function, but ECG rhythm may be analyzed. Evaluation of adequate battery function is possible, by applying a magnet to the pacemaker and observing the magnet rate. Sensing test. To test atrial sensing, program the pacemaker atrial rate temporarily to be less than the intrinsic sinus rate. To test ventricular sensing. With intact atrioventricular (AV) conduction in the single-chamber ventricular pacing mode, program the ventricular rate to be less than the intrinsic heart rate. With intact AV conduction in the dual-chamber pacing mode, increase AV delay to allow AV conduction and thereby allow for ventricular sensing. Alternatively, sensing test can be performed by increasing the programmed sensitivity level, until the intrinsic P or R wave is no longer sensed. In some pacemakers, there are automated sensing algorithms allowing automatic measurement of electrograms. Battery function. Almost all pacemakers use lithium iodide batteries. Battery life depends on the type of pacemaker, single or dual chamber, commercial model used, and how much active pacing discharge occurs. Some patients need little pacing, while others are completely pacemaker dependent. Battery voltage is usually 2.8 V at the beginning of battery life, which decreases to about 1.2 V at its end of life. Replacement indicators. For patient safety, battery replacement should be considered when any of the following indicators is detected. Decrease in pacing rate on magnet application. Increase in pulse width duration. Change to a simpler pacing mode. Reduced battery voltage. Elevated battery impedance. Restricted programmability. Battery check. The following indices are used for battery check. Elective replacement index, ERI. End of life, EOL. Safety measures. Elective replacement index, ERI. This is the level of battery voltage at which the pacemaker unit requires elective generator change. End of life, EOL. This is a lower battery voltage at which there is potential loss of pacemaker function, therefore, immediate generator change is mandated. Safety measures. When the battery function reaches the ERI or EOL stage, many pacemakers reset to the simplest pacing mode at a preset pacing rate, or the pacing rate is decreased. Rate-responsive pacemakers. Rate-responsive pacemakers require periodic adjustments of many variables to optimize clinical responsiveness. The programmable variables include rate-responsive upper pacing rate, a variable which may be separate from the upper tracking rate. Threshold for detecting activity, below which rate responsiveness is inactive. Rate response slope, may be programmed to determine the pacing rate at a certain activity level. Advanced features. Some of the advanced programming feature are Algorithms for automatic calculation of the appropriate heart rate, for brisk walking. Data recall, offered by the storage of certain information with respect to pacer function, for example, how much atrial or ventricular sensing or pacing was done, recall of certain events, such as episodes of atrial or ventricular tachyarrhythmia, etc. Chest radiograph. A standard chest X-ray, in the postero-anterior and lateral views, is recommended as part of the pre-discharge evaluation performed within 1 week of implant. To ensure appropriate placement of leads. To rule out lead migration. And to serve as a baseline for future studies. Non-invasive magnet test. Virtually all pacemakers are designed to pace in an asynchronous mode when they come into contact with a magnetic field. Single-chamber pacers respond to magnets by asynchronous pacing at either the programmed rate, or a special magnet rate. Test for oversensing. A magnet is a convenient short-term method to ensure pacing in patients who are pacemaker-dependent and experiencing oversensing. Elective replacement index, ERI, and end-of-life, EOL, magnet rates. Applying a magnet to a pacemaker is an easy non-invasive method to assess battery status, since pacemakers usually have one magnet rate for the intact battery, and another magnet rate for batteries at the ERI or EOL stage. Codes for cardiac pacing. Pacemakers are coded by specific abbreviations. A total of 5 letters has been defined by the North American Society of Pacing and Electrophysiology, NASP, and the British Pacing and Electrophysiology Group, BPEG. NASP, BPEG pacemaker codes. First letter specifies the chamber paced, 0, none, A, atrial, V, ventricular, D, dual chamber pacing, A and V. Second letter specifies the chamber sensed, also, O, A, V, or D. Third letter specifies the response to sensed events, O, none, I, inhibited, T, triggered, D, dual response, I and T. Fourth letter specifies the programmability, O, none, R, rate responsive, P, programmable, simple, M, multi-programmable. The fifth letter is rarely used in clinical practice, for defibrillators because of the increased complexity inherent in implantable defibrillators. Thank you.